All right, well, we are at 8 and we are ready to start. So thank you everybody for joining in for Grand Rounds. Delighted to see everyone virtually at the beginning of November. Hard to believe it's November 1st. I hope everybody had a healthy and happy Halloween. Before we get started, I do want to make one announcement and reminder. So our candidates for our dean, the School of Medicine dean search, they are coming through starting Monday. And just as a reminder, there is a town hall on Monday at 10 o'clock in HSLC. I encourage everyone to show up in person. I think it's great to show the diversity of our department and to welcome the candidates. I have heard that they are all outstanding candidates. As Dave Andes, our division chief of ID, is chairing the search committee. So rest assured, we've got great candidates. So Monday, 10 a.m., first candidate. The week after is the second candidate, and I believe there's 5 total. So please make every attempt to come in person. There is a virtual option for that as well, but I think it's great to welcome all of the candidates to campus. So with that, I'm going to hand it over to Dr. Janina Smith of Infectious Disease to introduce our special guest.
Fabulous. Thank you so much, Dr. Schnapp. So the great Paul Farmer said that the idea that some lives matter less is the root of all that's wrong in the world. With that in mind, it is my very, very distinct pleasure to invite and introduce Dr. Josh Barocas. Dr. Barocas was an AOA graduate of George Washington University School of Medicine and Public Health. You may remember him from such hits as his residency and Bridges Family Endowed Chief Residency here at the University of Wisconsin. He went on to do infectious disease fellowship at Massachusetts General Hospital, where he stayed as a research fellow and took his first appointment at Boston University. He is now the director of the Social Determinants of Health and Disparities Modeling Unit at University of Colorado School of Medicine. He is the recent former chair of the Infectious Disease Society of America Public Health Committee, and he's been a public health medicine advisor to a number of politicians. He has been on the CDC's Reform Task Force, and most recently, Secretary Bahara asked him to be on the board of scientific counselors. Dr. Barocas really embodies the spirit by leveraging his privilege to advocate and lift the voices of some of the most vulnerable members of society, including persons who are unhoused and those who use injection drugs. So to leave, I will finish another quote with Dr. Paul Farmer. If access to healthcare is considered a human right, who is considered human enough to have that right? Thank you so much for speaking for us, Dr. Barocas.
Thank you, Dr. Smith. It's a total and complete pleasure and honor to be able to give Grand Rounds at the place that trained me and sort of gave me some of the human rights principles that I try to live by. I was telling Dr. Smith before we start, you know, of all the talks that I give, I'll say I'm not going to look at who the participants are on the screen, because I would assume I know many of you, and it will make me more nervous talking to a crowd of peers and people that I respect and help craft me into the person that I am. So this is a wonderful privilege, and I appreciate it. The invitation. I appreciate Madeline for helping keep me on track and get everything in, and Dr. Smith for that very, very kind introduction. With that, I will try to spend the next little bit talking about what I think is one of the biggest public health, human rights, and medical issues of our time, which is the U.S. homelessness crisis, and how social and political determinants of health increase our risk for not just infectious diseases, but make us all a little bit more unhealthy as we don't necessarily, we haven't necessarily tackled this crisis from a public health angle. I do have one conflict of interest to disclose, but I will not be speaking on anything that has anything to do with it. And then I will leave this up, I think, for like 12 seconds and allow you all to use your phones to get session evaluation. This will be up at the end as well. And I report my funding. So today we are going to talk about three big topics in homelessness. One, because this is a medical audience, the unique health risks that people experiencing homelessness face. Two, to outline how punitive policies make people experiencing homelessness more vulnerable to these adverse health outcomes. And then finally, to sort of call to action, but really to explain how protecting people experiencing homelessness and housing insecurity protects the larger community, all of us, while protecting them. So there's no better way to summarize the health risks of people experiencing homelessness than this. People who experience homelessness die on average 30 years earlier than other Americans. This is the average age at which Americans died in the year 1900. So if you remember one thing from this talk, it's this. And in the next 45 minutes or so, I'm going to explore what it is that puts people at such risk for mortality. And if you remember two things from this talk, just remember, it doesn't have to be this way. So for several years, from about 2010 to 2016, homelessness in the US was on a slow decline. Unfortunately, in about 2017, it began increasing again and increased even more dramatically from 2020 to 2021. Largely, I think, from the economic hardship caused by the COVID-19 pandemic. Where we are at this point, there are about 650,000 chronically homeless individuals in the US. And it's hard to say, but at least 1.25 million people experience homelessness at some point in a given year. And homelessness is a spectrum. So we tend to think of this as people who are unsheltered, who are living on the street. But remember, homelessness runs the gamut. And I heard somebody say the other day, unless your name is on a lease, you could be considered homeless. And I want people to remember that couch surfing, that moving from place to place, that staying on at your aunt's house, for some people, that is experiencing homelessness. Now, when I say at least 650,000 people, at least 1.25 million people, I'm a bit skeptical. And part of this is the way that we count people experiencing homelessness. And I think that we have to start with where we are in the scope. So in the US, homelessness is typically estimated by the point in time count. This happens by jurisdictions using street level outreach and shelter data to count the number of people experiencing homelessness on a single night. Usually it happens in the wintertime, January, February. What it does is it relies on identifying and appropriately counting individuals. This is obviously flawed because we're limited by local resource constraints. We're missing people, as I said, who are hidden, who are experiencing homelessness at different times of the year, who just lost their lease, who are couch surfing. So despite the importance in local and federal policy decisions, point in time really only represents single point estimates, and we're likely substantially underestimating annual homelessness or chronic homelessness. So we presented some preliminary data at this year's National Healthcare for the Homeless conference on youth homelessness. And we specifically looked in Denver, Colorado, which is where I am now. We use linked data sources and a method called a multiple systems estimation. It was previously known as capture recapture because it came from Fish and Wildlife, counting deer and fish. But using the terms capture recapture seems inappropriate when we're talking about vulnerable populations. So in this study, which used the Denver Public Schools, the Division of Child Welfare, and the Metro Denver Homelessness Initiative. And what you can see is that there are sort of three distinct buckets in which youth are found to be experiencing homelessness. When we put those data sets together and then use some fancy modeling, which we can talk about, but it's too early and you all haven't had enough coffee. What we find is we can estimate the number of unknown people who haven't been reached by the system, but are out there experiencing some form of homelessness. And we did this for ages 14 to 17. And what we found is that as many as 1 in 4 youth, 14 to 17 years old, experienced some type of homelessness in 2021 in the Denver metro area. Just to put this in perspective, this is 6 times higher than what's derived from the point in time estimates. And so you can understand my skepticism when we're talking about that 650,000 homeless on a given night, 1.25 million who are homeless during the year at some point. These numbers don't account for non-congregate shelter, transitional housing, doubling up, couch surfing, all the forms of homelessness. So we're likely under-resourcing this. And as for the racial breakdown, I think it should be unsurprising that this is disproportionately impacting people from traditionally underserved racial and ethnic populations. Urban areas like my own in Denver, San Francisco, I think are illustrative of these challenges and the disparities. For example, Black individuals constitute 5% of Denver's total population, but represent 25% of its homeless population. San Francisco, which has one of the nation's highest rates of homelessness, again, Black individuals comprise 6% of the population, but account for nearly 40% of the homeless population. And among youth, individuals who identify as LGBTQ plus are significantly more likely to experience homelessness than individuals who don't identify that way. So for example, as reported by the Trevor Project, which is a wonderful organization, nearly 28% of LGBT youth reported experiencing homelessness or housing instability at some point in their lives. And those who did had 2 to 4 times the odds of reporting depression, anxiety, self-harm, considering suicide, attempting suicide, compared to people with stable housing. So as we dive into the health impacts of being homeless, I think it's important to remember, one, that we're probably, our scope is probably much bigger than what we think. And two, that who the populations are that are experiencing homelessness, and they're likely at increased risk of adverse health outcomes because of structural bias, systemic racism that's compounded by their homelessness. So what are these hazards of being homeless? Experiencing homelessness puts people at risk for communicable infections, weather-related injuries, cardiovascular disease, overdose, mental health, suicide, unintentional injury, abuse, and violence, just to name a few. So let's start with, I'm an ID doctor, thanks to Dr. Smith, Dr. Andes, Dr. Cernich. So let's talk about my specialty, our specialty of ID. People who are experiencing homelessness have higher rates of HIV than people in stable housing. We have known this for years. We've known this for decades. They also have higher rates of virologic non-suppression. According to some recent CDC estimates, at least 17%, and I'm going to say at least again, 17% of people diagnosed with HIV experience some type of housing instability. But of course, HIV is not the only transmissible infectious disease that people experiencing homelessness are at risk for. Homelessness has been shown to contribute substantially to the population burden of disease for tuberculosis, hepatitis C, and of course, COVID-19. But other studies have found things that we don't think about even that often. For example, a group actually here in Colorado found that Bartonella was shockingly common among people experiencing homelessness. Another group found that there was large disparities in the risk of invasive meningococcal disease among people experiencing homelessness compared to the general population. And finally, rhinovirus, which I think I recently contracted. So if I cough during this presentation, it's probably a rhinovirus. But there was consistent circulation of rhinovirus in shelters during the COVID pandemic. So this population was at risk, not just, well, the rest of us were sort of at risk for COVID and non-communicable diseases. All of these infectious risks were compounded during that pandemic, and we really haven't overcome that yet. And of course, these are just illustrative examples of communicable diseases. We've got others, including, as we learn in med school, body lice, scabies, bed bugs. These are easily transmitted, and while they aren't deadly, they certainly impact quality of life. They certainly impact ability to move out of homelessness, in fact. What about climate? This is something that's on everyone's mind these days. We're seeing the devastating effects of climate change, and not surprisingly, the greatest health effects are being felt most acutely by people living in poverty and people experiencing homelessness. In the summer, heat exposure and can cause heat exhaustion, dehydration, and heat stroke at high rates in this population. During the winter months, cold exposure causes injuries, as we all know, as you all know, living in Madison, frostbite, hypothermia, all of this leads to death. And extreme weather conditions like winter storms, severe heat, this is I think the most obvious place that we see this is unsheltered homelessness for people living outdoors. Older adults, people with substance use disorders, and those experiencing chronic homelessness. So actually there's a big Venn diagram. We have an aging homeless population. We'll talk about substance use disorders in a moment, but among people experiencing homelessness, this is a very common comorbidity of substance use. And then of course, chronic homelessness. All of this puts people at higher risk of adverse health effects from extreme temperatures. And then the one thing I think we don't necessarily think about all the time is malnourishment. Obviously, this is common among this population. And what it does is it actually decreases a person's ability to tolerate cold. And there does appear to be a compounding effect of cold weather and opioids, such that overdose is more common in the winter months. And of course, I think everyone on this Grand Rounds knows there's no shortage of documented risks for overdose, mental health, suicide, and violence in this population. I want to focus in a moment on the violence part, but just to talk about for a moment the mental health and the substance use, half of people experiencing homelessness have either a untreated mental health condition or substance use disorder. And I say untreated because we know that treatment for mental health disorders, mental health conditions, can actually help people move out of homelessness, and untreated mental health issues can actually make the transition into homelessness, I want to say, I hate to say it, but easier. There are higher rates of injection drug use, non-fatal overdose, and fatal overdose than people who are housed. And in the study that I think was just brilliant by Danielle Fine and colleagues out in Boston, you can see that overdose rates among Boston's homeless population were 12 times higher than that of the general population. I said I'd come back to the violence and the mental health, and I think that this is probably, if I'm going to point to the most depressing slide of the first phase of this talk, it's this. Suicide rates and violence are nearly ubiquitous in this population. In a 2012 study found that suicide rates in this population were 10 times higher for a homeless cohort compared to the general population. And another found that more than half of people experiencing homelessness have had thoughts of suicide or have attempted suicide. 80% of unsheltered women report abuse or trauma as the cause of their homelessness. 40% of unsheltered men and 35% of sheltered women say the same thing. I'm just going to leave this here for a moment. 80% of unsheltered women report abuse or trauma as the cause of their homelessness. So as we're walking down the street, as we pass people, and I check my biases during this as well, I think it's important that we remember that life experiences, a totality of life experiences, can actually lead to either unsheltered or sheltered homelessness. And oftentimes it is violence being perpetuated upon someone. It is oftentimes an untreated comorbidity that has led them to where they are now, because quite honestly, our society does not accept weakness. And we oftentimes see people who have been abused, traumatized, or have some sort of mental health issue as weak. So these don't just arise, right? These don't come out of nowhere. They come from somewhere. And over the next few slides, I'm going to walk us through what I think are the biggest 4 ways, I'm sure that there are more, both current and past, in which our policies and our practices make this population more vulnerable. First, number 1, we displace people, either through eviction from stable or transitional housing because we don't like how somebody's acting, because we don't like their characteristics, or through involuntary forced displacement, like during encampment sweeps. There have been a number of documented direct health effects, which we'll go into in a minute, associated with involuntary displacement. This increases people's risk for infectious diseases, climate-related injury, overdose, mental illness. But there are plenty of, I think, in what I would call indirect effects on health as well. And that includes loss of medications, ID cards, and then health-related items like glasses, hearing aids, and wheelchairs. This was a photo taken during what was coined Clean Sweep 1.0 in 2019 in Boston, at the corner of Massachusetts Avenue and Melnia Cass. This is more or less where Boston University Medical Center and Boston Medical Center are, or sorry, Boston University School of Medicine and Boston Medical Center are, which is where I started my faculty career. And one night in um, in the middle of essentially the summer, the police were deployed to clean up, quote unquote, the streets. And what you can see is that in some cases, wheelchairs were disposed of. We did a study that came out in 2023 in JAMA. It was a modeling study that simulated the health effects of continued or continual displacement risk. Not even, getting displaced on a continual basis, but just the risk of it versus sort of a world in which there was no displacement. That's one of the nice things about doing modeling, is that we can come up with counterfactual worlds that we may want to live in. And what we did is we looked at a cohort of people experiencing homelessness who inject drugs. We used data from 23 cities to develop cohorts that were representative of this population. And we ran thousands of simulations with various changes in parameters. What we found, and yes, it's a modeling study, but under no circumstance, under thousands of simulations, did our health outcomes for this population improve or remain even neutral over 5 and 10-year periods into the future. So in fact, in every health outcome, overdose, endocarditis, skin and soft tissue infections, and hospitalization, so this impacts our healthcare system as well, these were all worse. We found that sweeps, that sort of the risk of involuntary forced displacement would likely contribute to 25% additional mortality in this population over the next 10 years. Other studies have demonstrated the impact of involuntary displacement as well, including one led by Ashley Meehan, which showed that among about 400 people experiencing homelessness in Denver, involuntary displacement was significantly associated with self-reported infectious diseases, substance use and alcohol use, climate-related conditions, and worsening mental health after controlling for all potential confounders. And now, unfortunately, it's completely legal to displace people. In June of 2024, this year, the US Supreme Court overturned Grants Pass versus Johnson, which made it legal for cities to punish people experiencing homelessness for sleeping in public. Some cities like Grants Pass and San Francisco have actually already begun fining and ticketing people, as well as incarcerating people. And I know that a number of other cities throughout the country are weighing their options. And what I'll say is that displacement, either by eviction, sweeps, etc., not just impacts someone's health right there, but it also depletes an individual's social capital. And social capital, for just to put this in perspective, social capital is the resources and support that people derive from their social relationships, networks, and community. It's a construct, but we can quantify it through things like proxy measures of social cohesion, civic engagement, network connectedness, and trust. Social capital is necessary, but not sufficient to prevent homelessness in the first place. It's also necessary, in my view, but not sufficient to help people emerge from homelessness. And what Grants Pass versus Johnson, the Supreme Court case, has done is more than impact the direct health. It's authorized government officials to, in my view, bankrupt individuals of their social capital assets. And Grants Pass is just one example among tons of policies and practices that inadvertently or advertently impact health and decrease social capital among people experiencing homelessness. According to the National Homelessness Law Center, as of 2021, it hasn't been updated, 48 states have at least one law restricting behaviors that prohibit or restrict conduct of people experiencing homelessness. 24 states have laws restricting loitering, loafing, and vagrancy in particular public places. 4 have laws restricting lodging, living, or sleeping in vehicles. In vehicles where that may be your last refuge. So this is just one example of how we as a society are impacting the health of this very vulnerable population. Number 2, we discriminate against and exhibit a very strong bias toward people who experience homelessness, I think in both large and small ways. So this sign, which we've all seen, there are obviously, as an ID doctor, there are hygienic reasons that we want sometimes this policy in place, but just believe it or not, this phrase, this no shirt, no shoes, no service, actually originated in the 1960s when businesses wanted to discourage hippies who didn't necessarily always wear shoes or shirt from entering their stores. But what we've done is we've used this to exclude people who are impoverished, people who may not have the proper footwear at any given time. And I think that public perception of increased homelessness associated crime has outpaced the growth of unsheltered and even sheltered homelessness, which has fueled demands for police-based responses, including displacement. So the popular narrative seems to be that we need to get people away or displace them because homeless people commit crimes. Let's just speak plainly. That is a big bias that I think many people. And so if we displace them, then it relieves crime. Well, there's very little evidence suggesting that on either side. One evaluation from Skid Row found that a carceral police intervention had only a very modest decrease in crime, and then there were continued overall trends in high crime. Another study in 2017 from the Bronx showed no significant difference in nearby crime complaints following an encampment closure. That was just a case study. Understandably, this is very hard to measure. So we measured it. We did this analysis. It just came out. Perfect timing for this talk, really. This was led by one of my graduate students. It was published in the Journal of Urban Health. And we performed a spatial temporal analysis to dissect the association between involuntary displacement or sweeps and crime. What we did is we geolocated and timestamped every sweep and every crime in the city of Denver from 2019 through the summer of 2023. We assessed crimes 7, 14, and 21 days following the sweeps at a quarter mile, a half mile, and 3/4 mile. And we found overall that there was no reduction in crime. Now, there was brief decreases in public disorder and auto theft at 0.25 or quarter mile, which is about 2 city blocks at 7 days, which was about 1 crime per week. These dissipated at larger radii and at longer periods. So what it means is that our crime, essentially, if we move people, it fills back in, and it's not necessarily just the result of people experiencing homelessness, and that our unhoused neighbors are really no different than those of us with stable housing, but we like to think that they are when it comes to crime. There's this stigmatized belief that homeless people are a crime-ridden population, and we characterize them as such, but really my point is that allowing homelessness to exist is, in the first place, is the actual crime. Third, we're just going to call it's structural racism. I discussed earlier in the talk that homelessness is deeply entwined with race and racism. The criminalization of homelessness is fundamentally a racial issue. There was a very profound report entitled Slavery as a Cause and Consequence of Homelessness in the United States that came out. That the structural racism against Black, Indigenous, and other people of color presented today by the criminalization of homelessness is rooted in intentionally racist policies. So the criminalization of homelessness includes loitering, vagrancy, and other laws, bans on camping, sleeping, sitting, lying in public, and asking for donations. These laws are enforced close to 10 times more against Black individuals who are experiencing homelessness than other racial groups. The Committee on the Elimination of Racial Discrimination obviously expressed its concern recently about the high number of homeless people who are disproportionately from racial and ethnic minorities and the criminalization of homelessness through laws that prohibit activities, as we've talked about. These laws fundamentally impede an individual's freedom from cruel, inhumane, and degrading treatment. These aren't different than Jim Crow era laws and those that preceded with slavery and those that came after with government sanctioned redlining. Remember, redlining was the systemic exclusion of people of color from the housing market through essentially racist tactics that were, and so people were excluded from home ownership. We've never allowed people, specifically Black people, to live or exist where they want or need to exist. And our current laws reinforce this paradigm. Finally, just as bad as causing harm to this population, we rarely, if ever, develop policies that protect them. As you can see, statistics at the bottom by the National Coalition for the Homeless, people experiencing homelessness experience large numbers, high numbers, relative to the overall size of the population of anti-homeless violence. 97 incidents of anti-homeless violence between 2020 and 2022. Of course, we also know that people experiencing homelessness do not report crimes against them as often as people who are stably housed. People experiencing homelessness are likely to experience being the victim of a crime. And I can't say more likely because we haven't been able to study whether they're more likely to perpetuate or have a crime perpetuated against them. But we know that this is a vulnerable population that oftentimes cannot protect itself. This is a picture of Jordan Neely, man who was killed in the New York subway, experiencing homelessness, put in a chokehold. In LA, nearly a quarter of all homicide victims were homeless. Cities like Las Vegas, Portland, Miami, they have murder rates among unhoused people that are roughly 200 per 100,000 people. That is astronomically higher than the national average of 8 per 100,000 people. We do not protect this population like we should. A recent study that came out of a very large statewide study in California showed that 74% of the 3,200 participants in the study had experienced violence in their lifetime. During their current homelessness episode, so of course people cycle in and out of homelessness, 38% experienced physical or sexual violence. And this is compared to 1% of the general population annually. And what you can see here is that factors associated with current violence included drug use, unsheltered homelessness, and childhood abuse. There are also other ways that we don't protect people. One of those is from climate-related injuries. In 2022 through 2023, the average temperature here in Denver was about 32.9 degrees Fahrenheit, freezing. We had about 1,000 adults that we knew were unsheltered. At the time, other cities, many cities, had extreme weather response plans, what are called code blues, that were at least reasonable. For example, Vancouver, notoriously cold, enacted their cold weather code blue when there was a forecasted temperature or wind chill of 0 degrees Celsius or colder, any snow accumulation, and rain or at or near freezing temperatures. So when people would freeze, they enacted their cold weather emergency. New York instituted their cold blue, or institutes their cold blue, when that temperature drops to 32 degrees or below, including wind chill, and when it's going to be between 4 p.m. and 8 a.m., the times when people would otherwise be sleeping. Denver, on the other hand, had this very arbitrary threshold for overnight temperatures of 20 degrees or below, a wind chill advisory, watch or warning, or 2 inches or more of snow in the forecast. And that's only when the existing shelter system exceeded its capacity. There is no scientifically valid evidence that I have found that supports this temperature threshold. Luckily, at this point, with some advocacy and a lot of work with the city council and the mayor's office, this has been raised to 25 degrees, and we're opening 24-hour cold weather shelters for times when it is forecast to be 25 degrees and below. So there's slight movement, but again, we need to be making policy that's informed by evidence. 25 degrees really doesn't have any evidence. It's arbitrary. For what it's worth, the only policy that I could find in Madison in preparation for this talk was that extreme cold is defined when overnight temperatures are forecast to be 20 degrees or below. There was not a wind chill or precipitation parameter. So in Madison, there is this same non-evidence-based policy that we enact our emergency shelter. It's not just Madison, it's all of Dane County, this emergency shelter at 20 degrees. So I've spent the last 40 minutes. Why should you care? Why should you care? Beyond the humanist arguments that I can make, why should you care? Why should a stably housed, largely, and a big assumption, stably housed audience care? Not to sound alarmist, well, sort of to sound alarmist. Our collective survival depends on us caring. I believe that continued neglect of this vulnerable population will most certainly lead to considerable strain on the already stretched healthcare system. Without even accounting for a new pandemic, increased transmission and mortality from infectious diseases within and outside of this population are likely. Why? Because viruses and bacteria do not abide by class lines, by poverty levels, or by census tracts. And this, our continued neglect, is widening a health disparity gap. A lot of research shows that we are all affected by human suffering, not just our, coughs and our immune system, but our mental health, our stress, our quality of life. And so by helping and by not neglecting this vulnerable population, we're actually allowing everyone to lead their healthiest lives. Illustrative of this point was a phylogenetic, and I'm not a phylogeneticist, so it took me about 35 times to read this paper to understand 7 words. But this was a phylogenetic analysis of the COVID-19 outbreak in Boston. It was published in Science way back in the early part of the pandemic. And if you can recall, there was a large super spreader event that occurred at an international business conference in March. And during this conference, several hotel workers became infected. Those hotel workers happened to reside in congregate shelter. So this large outbreak emerged among people experiencing homelessness in Boston. And if you also remember, there was a paper that came out that showed that a large number of the homeless population in Boston was actually asymptomatic. So as we're circulating and recirculating the virus at this large conference, some of it first came to our unsheltered and our homeless population, and then it was brought back to the conference because people were unaware of their status. The other way around, this super spreader event, and there was also one at a SNF, made Boston one of the most affected cities in the first months of the pandemic, leading to, as I was there, an outsized mortality compared to most other cities. It turned out that many of the folks who became infected with COVID, for whatever reason, who were experiencing homelessness, were asymptomatic. We still had high mortality, but there was a large asymptomatic population. We had outsized mortality in Boston at the time that came through this super spreader event. Again, why should you care? Aside from it being the right thing to do, protecting people who experience homelessness actually makes us all a little bit more stable, specifically economically stable. So we'll go back to this Denver thing for a minute. We looked at some data from one Denver metro area hospital. We found that the winter that we were talking about, there were 49 encounters at this one hospital for cold weather injuries, mostly frostbite, and the average stay was about a week. So we took the back of the envelope calculation using the Kaiser Family Foundation estimates for a day of hospitalization. We estimated that costs would range from about $110,000 to over $1 million per year per metro area hospital. So if you take in the metro area hospitals, you got $5 million at the maximum for weather-related cold injuries, just among people experiencing homelessness. So, and of course, we all know that this is oftentimes uncompensated care and or Medicaid. So taxpayer dollars. It turns out that warming shelters, we looked into this, cost no more than $50,000 a day. And that's actually a high estimate. So speaking to the Madison crowd here, if we opened a 24-hour warming shelter for all 90 days of winter, and I know that you guys have 180 days of winter, it might actually end up saving us money. And if it doesn't save us money, it's really on line with how much we're spending in uncompensated care anyways. So not only is it the right thing to do, not only does it make us more stable, all of us healthier, but at the end of the day, it's also the economically reasonable thing to do. So this is the end of the talk. This is when you expect me, the speaker, to provide sort of this synopsis, pearls of wisdom, bottom line, closing remarks. And I think that if this were a talk for improving care for patients with myocardial infarction, I think that wrap up would do well. But I put this talk together and it just didn't seem to fit. Yes, people are suffering. People who are homeless are dying rapidly and painfully. They're criminalized, they're brutalized, marginalized, scapegoated, spit on, and swept aside. All of this makes their lives worse. It makes us worse. It creates a hostile environment. It creates an unsafe and unhealthy environment. So I'm going to close, take questions by saying simply, it doesn't have to be this way. Thank you. I left some time for questions. I will put up the link to the session evaluation and I'll turn it over to Dr. Smith.
Fabulous. Thank you so much, Josh, for this very impressive and sobering talk. We do have one question so far in the chat and some lovely comments, of course. Farah Karsau asks, do you think solutions to these problems are best approached at the local, state, or federal level, or a combination of all of the above?
The answer is yes. Absolutely. I think part of the reason that I bring up, for example, Madison's cold weather. This is a very easy fix at the local level with a little bit of back of the envelope math where we can just point out, you in Madison can point out that the shelter conditions or the cold weather conditions for sheltering are not evidence-based. We have a platform as evidence-based scientists, as people who take care of this population, to say this is impacting our hospital. This is impacting not just my patient, but it's impacting our hospital. It's impacting our Dane County. And if we raise this temperature threshold, it's really not going to cause a whole huge disturbance in the force. It's just going to perhaps make a few more people safer. I would say that as local jurisdictions now, specifically in light of Grants Pass, local jurisdictions get to make their choices. And it was put on local places to say, we get to do whatever we want because we've now criminalized sleeping. It is an opportunity for local advocacy. And I want to just be very clear. When I say advocacy, I mean evidence-based advocacy. We have an evidence base that says this is bad for people's health. Similar to putting, I just heard Dr. Califf from the FDA. The FDA is trying very, very hard to put the nutrition facts on the front of packages, which is a form of advocacy for health. Because we know that people don't look at the back of packages. And if it's right in front of you, you're actually more likely to make healthy choices. I'm not saying to advocate, I'm certainly not saying to advocate for non-evidence-based practices. What I've told folks is if the research were showing that, for example, sweeping people during cold weather was good for their health, then we should all be on the front line saying, let's do it. But that's not what the evidence says. And we need to be an evidence-based group of advocates that say this is bad for our patients, and here's the alternative. So whether it's at the local, state, or federal level, the answer is yes.
Fabulous. Dr. Trowbridge asks, what are some first steps for intervention in advocacy?
Thank you so much for that. I'm going to stick on the cold weather because it's easy right now. I assume that at least Madeline was telling me it's still 60 degrees and beautiful in Madison, but it's probably not going to stay that way for much longer, having lived there. You have a very sympathetic city council. You've got sympathetic politicians who, when they have evidence in front of them, it can be simple letters to the mayor, to the city council that say, here's our shelter policy. This is not evidence-based. And if we increase, and here's the number of people that the University of Wisconsin hospitals and clinics served last year with frostbite who were experiencing homelessness. And here's the cost savings to our community if, in fact, we just allowed people safer access to shelters. Dr. Trowbridge, just an excellent question. That is one small example. But I think that it's illustrative of that local one step. This is the analysis that we did was not a very good one, but we got of the cost to the hospital system. But when you are able to sit as a evidence-based advocate in front of your local politicians and make that argument, especially when there's a cost argument and a humanistic argument tied together, then you actually appeal to all sides of the political spectrum.
Fabulous. Dr. Barzi asks you that mentions that engaging the population requires relationship building, and this can be challenging in a population where there's a lot of mistrust. Do you have any community engagement strategies to help reestablish trust from housed individuals to this vulnerable?
Yeah. Dr. Barzi, excellent question. And the best community engaged strategy that I know and that I employ is working already with sort of having a trusted community liaison, someone who's either in a peer capacity or someone who has had lived or living experience, that you first build that trust with that one individual and say, I'm here for this community. And if you can build that trust with that one person, we have a book at our house that it just takes one. If you can build that trust with that one person and say that your objective is beneficent and you're trying to really truly engage, break down the silos, then actually that person can be your trust building bridge. We do this with studies. We do this with care all the time. It's not about me, Josh Barocas, walking into a community and saying, guys, I got you. I'm going to help. Look at me. I've got a beard and black glasses and, like you could trust me. It's about building that trust with one or two individuals first, and then having them vouch for you.
Fabulous. And the last question in the chat said, many of the reasons we see carceral justice solutions for the homelessness crisis is due to pressure from business sector of cities and for tourism. How do we better persuade local governments that the current ways we engage with persons experiencing homelessness are harmful to the community? versus the economy.
And before you answer that, we are at 9 a.m. So I want to be respectful of people's time and your time. You and Joe and others are welcome to stay on, but I also want to thank you, Josh, for, I wouldn't say a cheerful discussion, but a sobering reality. And I think my take home from all of the input is how much control we do have at the local level. Many of these decisions do reside in the local communities where we should have influence and maybe a little bit easier to impact policy than necessarily at the state, certainly at the federal level. So I am heartened by that we do have opportunities to make a change. We are a school of medicine and public health, so it is within our lane. And so with that, I would say go out and vote. And vote early, vote often. And as a reminder, our patients are eligible to vote. So we have a mechanism to allow our patients who are hospitalized to be able to vote absentee. If you need information, it's online at the Pulse. So Josh, I don't want to
no, absolutely. I think that is an amazing way to end. You're right. That the greatest power that we have is to vote and help our patients vote.
Okay. All right.
Thank you so much for this.
And I'm sure Josh will be available by email or additional chat for additional conversations. So thank you in advance.
Absolutely. Thank you so much.